The next speaker is Richa, Dharap, Endoscopic Dacryocystorhinostomy.
A very good morning to all. So today we'll be looking at endoscopic dacryocystorhinostomy as a form of video skill transfer. So I have no financial disclosures. Before diving into the basic points and other things, I would like to take you through a video of the procedure to help you understand better. So this is the left nasal cavity, and that's the left lateral nasal wall. So a U-shaped incision is usually done anterior to the axilla, 10 millimeters anterior and superior. As soon as that is done, the periosteum elevator is used to elevate this mucosal flap. Once the bone underneath is revealed, this is basically the last step that we do in external DCR, raising the nasal flap that we are doing first in the endoscopic DCR. The bony junction is usually as a sharp right angle between the maxillary and the lacrimal bone, and putting your punch easily can perforate the lacrimal bone, and we can start the punching using rongeurs. So the initial part of the punching is done using rongeurs quite easily. We can see the sac that is underneath it. To confirm the presence of the sac, a simple application of pressure, just like we do for Roplas, is done, and the indentation over the sac is easily noticed. Once we punch all the bone that we can access with the rongeurs, the flatter and the more tougher part of the bone is dealt with a power drill. Now over here in the particular video, a Medtronic drill is being used, where a suction and irrigation along with the power drill is together with it. But of course, this is not available in all places, and this is very expensive. So even a simple mechanical drill along with a manual suction and irrigation can easily be used. The purpose of this is basically to clear the superiormost bone that is sitting in front of the common canalicular opening, so that the common canaliculus is free at least around 5 millimeters. So this is just smoothing of the bone around it. So we can see that there's a good clearance all around the common canalicular opening. That was the probe that was being inserted. The lacrimal bone that we initially perforated, sometimes many pieces of this are still sitting over there, so we need to make sure that all of that is removed prior to the opening of the sac. So the sac is inside using a crescent knife. Now this is a unique step that I have seen Dr. Javed Ali use. He was my trainer during fellowship. The ENT surgeons usually use a sickle knife, but a crescent blade is easily available in most of the ophthalmologist setup, so I don't think that should be a problem to get. So once the flaps are created, they are reflected like an open book. Mitomycin C is applied to the bony ostium, and then bicanalicular intubation is done. These two steps are not compulsory. They were performed as a part of routine procedure during our fellowship. The nasal mucosal flap that we first raised is then trimmed in such a manner as to oppose the posterior sac flap, as well as cover the superior bony ostium as much as possible. This is a ball probe that is helping to turn the nasal flap and oppose it towards the sac flap. Glue is then applied to keep these surfaces in apposition. Again, this is not a compulsory step. The blood, the thrombin, fibrin also works equally well. Intubation is then tied, and then suctioning of the nasal cavity is performed. Suction tip has to be away from the site of the surgery during this final suctioning. And then a fresh nasal pack is placed, ensuring that it does not entangle within the intubation. So now that we've seen the procedure, just looking at a few rules to master endoscopic DCR. So, knowing the anatomy, of course, is of prime importance, but this is something that we've always seen throughout our MBBS textbooks. But the in vivo picture looks something like this, very different from what the textbook showed. So, this is the middle turbinate, and this is the axilla, and we have just seen that where we need to incise. And the nasal anatomical variations are very, very frequent. So one must be aware of them. This is actually an ethmoidal bulla that is looking like the middle turbinate. And once we retract it, then only the middle turbinate can be seen. In this particular case, the middle turbinate itself, the anterior end is very much enlarged, that is known as concha bullosa. So the sac is very much posteriorly placed. In order to have a good access and opening of the sac into the nasal cavity, we would have to do a middle turbinoplasty in this case. So keeping these things into consideration. Now knowing the equipment, so this is a typical console unit that we see on the right. On the top is the display, then we have the camera head and the light source. The light source varies from xenon, halogen to even LED nowadays. LED is basically the white light that we usually see in the scopes nowadays. And on the left is the Hopkins telescopes. So 4mm ones are used for operating usually and 2.7 for the clinic. One can start out as any uncomplicated pandos and roomy nasal cavities that are basically not have been operated before. Of course, one needs to be very comfortable with an external DCR prior to moving on to an endoscopic DCR. As one gains more experience, acute setting cases, acute lacrimal abscesses, repeat lacrimal surgery, ostium procedures like balloon dacryoplasty, narrow nasal cavities like in this particular case, or post-ENT surgery, this case underwent FES, and adjunctive nasal procedures like I discussed regarding the middle turbinoplasty can be attempted. Limitations also must be a part of your understanding before you move on to the surgery. So post-trauma, lacrimal sac diverticula, where you might want to externally expose multiple areas, lacrimal rhinosporidiosis, need for any additional external surgery, and last but not the least, definitely when you're out of comfort zone, avoid going ahead with this surgery. Apart from the systemic clearance, a good hypotensive anesthesia and a nasal decongestion prior to starting the procedure. These are merocil sponges that are dipped in 1:10,000 adrenaline, and then a mucosal infiltration is done with 1:80,000 adrenaline, following which the nasal packing is done, and then we start the procedure in the next 10 to 15 minutes. This gives a good control of bleeding during the surgery, good hemostasis. So we had a look at most of these equipments. So the micro debrider is something we didn't look at. It's basically a very fine, it does the job of a very fine scissor. It trims the mucosa as required, and it gives a very smooth cutting edge, but it is extremely sharp, and narrow nasal cavities is something to be borne in mind. The other things we've already seen, the diamond burr, mitomycin C, and intubations. So apart from all the routine instructions for a external DCR, the advantages of endoscopic go about no restriction of head bath and no external wound care. So it's a faster rehabilitation. So to conclude, how, what, and where do you start from? So examining, starting with the endoscope and getting familiar with the endoscope to identify the normal anatomy, recognizing the variations. And the best way to start this is by examining DCRs of external, ostiums of external DCRs that we have previously operated in the clinic. Starting slow, I'm sure everybody over here uses a lot of equipment, including phaco, so developing a hand-eye coordination won't be an issue. So slow instrument handling and step-by-step processing in successive cases. And last but not the least, having an open mind about keeping a backup, either help from an experienced surgeon, it may be any oculoplasty surgeon or even an ENT surgeon who is experienced with this surgery, and converting to an external DCR if we're stuck in the middle of the surgery should always be kept in mind. I would like to acknowledge my mentor, without whom any of my endoscopic presentations are incomplete, Dr. Javed Ali. Thank you so much for your patient listening.